Hello and welcome to this talk on 4G deformity correction with fixator assisted nailing and plating. This was given at the Indian Orthopedic Association annual conference in December 2017. We know about fourth generation telephoning. We reap the benefits of high speeds and user satisfaction. So it is my brief in this talk to explain to you about the fourth generation of deformity correction. That's 4G that we are employing these days. The first generation of deformity correction started with Nicholas Andry in 1760s. On the left, you see the famous picture of the tree, the splintage to the stalk, which is used very commonly in all orthopedic logos, and an English language translation of the original article that he wrote in 1767. A British Journal of Bone and Joint Surgery editorial of 1991 highlighted Nicholas Andry and the influence that he had on 250 years of orthopedy, that's correction of crooked limbs in children and adults. The methods of deformity correction employed chiefly consisted of simple tools like K-wires, plates, using closing wedge osteotomies with plasters, etc., without much consideration to the mechanical axis and the effect that it has on the joints above and second generation of deformity correction came in the late 1980s with the spread of the Ilziarov technique from Russia to the rest of the world. I was fortunate enough to be part of the advancing wave of this knowledge front, having met and learned from Professor Ilziarov and his most illustrious pupil, Dr. Dror Paley, who learned the techniques in Italy in 1986 and also from Kurgan. And I was fortunate enough to be on a fellowship with Dr. Paley in 1988 at the University of Maryland in the USA. With the Ilziarov technique, we can perform deformity correction either gradually or acutely at one level or at multiple levels, regardless of the extent of the deformity, to give dramatic correction of deformities, as you can see in this young lad on the left with very significant valgus, external rotation, and procurvatum deformities, or in the case of this 30-year-old lady who's a dwarf, achondroplastic dwarf, and also a professor of English and history who had acute deformity correction of the tibia both at the upper and lower levels. We also have the example of this lady who has a very severe varus recurvatum internal rotation deformity along with shortening. Accurate placement of hinges allow us to correct all the deformities of the varus, recurvatum internal rotation, as well as shortening to give her a completely straight limb with equal lengths. However, the complex planning needed for the correction of these deformities and the montage changes prompted John Charles Taylor, professor of orthopedic surgery at Campbell Clinic in Memphis, USA, to invent the Taylor Spatial Frame, which is a software-controlled 6-axis correction fixator, which enables us to correct complex deformities, including angulation, translation, shortening, and rotation, with ease of application of the fixator and ease of correction because we don't have to perform the calculations, the software does that, and we don't have to have hardware changes of montage because the 6 struts that are used have multiplane hinges at both ends and can perform these corrections without repeated changes in the fixator, which are labor oriented. Some examples: this young lad with a very severe procurvatum and varus deformity in the femur with recurvatum and valgus in the tibia with rotations and shortening was corrected completely using the fixator to give him completely straight limbs and an accurate correction. So finally, coming to the fourth generation of deformity correction is when we marry the comfort and convenience of internal fixation, either locking nails or locking plates, with that of the accuracy that is given to us by external fixation. This enables us to reduce the time in external fixation and dramatically improve not only the comfort of the patient, but enable early range of motion and resumption of activities of daily living. With examples of fixator-assisted nailing. Here, the external fixator is used as an intraoperative alignment tool and for lengthening whenever it is. Lengthening over nails was first described by Bost in 1954, but was chiefly popularized by Paley in 1997 in the landmark article in JBJS American. Koshaglu from Turkey reported on complications in this method in 2004, and myself, Chowdhury, reported in the Indian Journal of Orthopedics in 2007 on early experiences in limb lengthening. However, when we perform deformity correction using intramedullary nails, the game becomes much more, and we need special instruments in order to perform accurate correction. First of all, we need good high quality full length digital X-rays, such as in this wall mounted system from. We need special instruments that are designed to achieve entry point accuracy, as these set of instruments help designed by me and marketed by a company called Manman in Pune, which enable us to get accurate anatomical lateral distal femoral angle of 81 degrees when we insert the nail in the lower femur with thin walled reamers and bushing. The most important fact is we need to use straight and rigid cannulated reamers and straight nails as opposed to flexible reamers or curved trauma nails. We also make use of polar screws in order to narrow the track of the nail and direct the nail in order to achieve accurate correction. This represents the entire set that needs to be used for deformity correction using IM. So let's begin with a few examples. Here is a person with a valve deformities, very severe deformities in the femur and the tibia. You can see there is significant valgus in the femur along with pro. Now this animation hopes to explain how we perform the surgery. You can see external fixation pins are inserted initially posterior to the track of the nail. An incision is made distally and we measure the LDFA at 77. We use this jig of 81 degrees, pass in a guide wire at exactly 81 degrees to the joint orientation line, like so. Over the guide wire, we pass in thin walled reamers called as clouards, and then narrow the track of this nail by putting polar screws on either side. With the help of the bushing, now to protect this track, we now make holes with drill bits in a curved fashion, complete the osteotomy with a sharp 5 mm osteotome, and correct the deformity with the help of the X-fix pins. Straight rigid reamers create the track for the nail in the proximal fragment. The LRS fixator maintains the deformity correction while we insert the nail and lock it above and below. If we want to perform lengthening, we do not have to lock it above, and the fixator will help us to lengthen. If we only need to perform deformity correction, then we are done with the job. So you can see in a similar fashion, we have performed valgus deformity correction in the femur along with procurvatum deformity at an upper level. You can see the nail has been locked at the lower, middle as well as the upper levels such that both the levels of osteotomies are corrected. He also went on to have a valgus correction in the femur, in the tibia with the Ilziarov fixation in order to get a good correction. These show the steps of the operation. The X-fix pins are inserted posterior to the track of the nail. These are the blue colored titanium pins. A small incision helps us to make an opening. And the guide wire is passed. Thin walled reamers are passed on top. The around, and you can see he has got a very accurate correction with his mechanical axis passing exactly through the center of the knee. As you can see on the x-rays on the right, a lateral translation of the distal fragment is needed to help line up the axis of the proximal and the distal. What if we have a shortening, as in the case of this obese young lady who would not tolerate an external fixator? In the previous case, the fixator was removed at surgery. However, since we want to perform lengthening in this young lady, the fixator would have to be on the leg for at least 6 to 8 months if we only chose to perform it using the second or the third generation devices like the Ilziarov or the TSF frame. In order to time, we use the fixator assisted nailing technique as explained. And you can see she has a nail inserted from the distal level, the LRS fixator in situ, which allows her to sit and perform activities of daily living, a very small incision with a small dressing, and the fixator comes off in hardly 6 to 7 weeks with a full length achieved. Early removal of the fixator along with full correction of the deformity enables her to have a full range of knee motion as well as sit cross-legged on the floor as is needed by most of our. This is a young gentleman who's a gym trainer and a television actor who has poliomyelitis with fixed flexion deformity of the knee. So he walks with a hand on the knee and he has got a mild amount of shortening. So the x-rays on the right show how we do the pre-op. And we have performed with the help of the fixator a double level osteotomy, as can be seen on the second x-ray from the left, a supracondylar osteotomy at the lower level with mild posterior translation of the distal fragment, as well as a proximal osteotomy to help achieve length. The third x-ray shows that the length has been achieved at the proximal osteotomy. You can see the nail has been fixed at both the distal as well as the middle levels. The fixator is low profile and allows much comfort and conservation. And you can see the fixators come off in 6 weeks. The osteotomy is healed really quick, and rehabilitation proceeds at a really fast clip in these patients. Varus and procurvatum, as in this lady with significant deformities due to rickets, we focus on the in which we performed a double level osteotomy to help correct the varus and the procurvatum. You can see the polar screws on either side of the nail and the fact that the nail was locked both in the distal, middle, as well as in the proximal fragments. On the opposite side, she went on to have a correction with the help of the Ilziarov external fixator both in the femur and the tibia in order to achieve the deformities like so. Procurvatum deformities in this young lady from Kolkata. The significant varus was accompanied by procurvatum deformity in the femur, very significant procurvatum and varus in the tibiae. So we chose to perform in both the femora double level osteotomy correction using a proximally inserted nail with two osteotomies, the proximal one being to correct the procurvatum and the distal one being to correct the varus. A TSF fixator was inserted in the tibia to correct the procurvatum at the upper level as well as the varus deformity at the lower level. Was given on the opposite side, and you can see the very accurate correction of the axis in both the femora as well as correction of to give her a complete correction of her axis, straight limbs, and a very good correction in both the coronal and the sagittal planes as well. What about this gentleman who's got a non-union in the lower end of the femur with a nail in situ with 3 centimeters of short? He was to perform fixator assisted nailing. As you can see, we have inserted the nail from the proximal end. There are two osteotomies. There is one osteotomy at the proximal level for lengthening, and at the non-union site, we have performed a lateral translation of the distal fragment and compression at the non-union site by locking bolts in both the distal as well as the middle fragments. The LRS fixator achieves the lengthening. The nail slides down. As soon as length is achieved, the nail is locked at the proximal level. It's off in hardly 6 weeks. So you can see very early that he has, within a 6 to 7 weeks, he has achieved, union at the non-union site as well as the fixator has uh, been removed and the lengthening has consolidated in a really quick time. The fixator has come off early, which enables him to have almost full range of motion. This is another patient, a software engineer, 36 years of age, with a significant varus malunion in the lower femur as well as a little bit of procurvatum. We performed a lengthening over a nail. The nail was inserted from the proximal portal and was kept long. And you can see an osteotomy was made in the upper femur for the purpose of lengthening. And then the malunion was corrected at a distal osteotomy in which we did a lateral translation. The nail was kept long at the proximal level and the distal fragment was fixed. The distal osteotomy was fixed with bolts in the nail both at the distal and the middle levels. Lengthening was performed at the upper level with the LRS fixator. The fixator came 7 to 8 weeks and enabled him to get full correction of his leg length discrepancy and deformities like so, to get early range of knee joints. This young lad with Olier's disease had varus recurvatum and internotation deformities in the lower end of the femur with 15 centimeters of shortening. Correcting him only using external fixators would take really a long time, more than a year in the fixator itself. For that, we chose to perform fixator assisted nailing in which the nail was inserted from the proximal level. You can see that the nail has been left protruding out from the proximal end to a significant extent. Two osteotomies are performed. The distal osteotomy helps correct the recurvatum deformity almost completely, and the proximal osteotomy is to achieve lengthening. There is a central locking bolt which helps to lock the distal osteotomy, and the nail slides in, as you can see, and it has come within the femoral shaft even though it was protruding by 7 to 8 centimeters outside. An upper tibial lengthening is performed with the help of the Ilziarov fixator and hinges at the lower level. The fixator comes off really quick in the femur, which enables him to have good range of knee motion within a few weeks of the fixator removal. And his leg lengths are now equal and mechanical access passes through the center of the knee joint. Young school teacher, about 36 years of age, has significant instability in the ankle due to poliomyelitis and 4 centimeters of shortening. External fixation to perform both the tasks of ankle arthrodesis and tibia lengthening would no doubt be extremely successful, but the fixator could stay on her leg for as long as 8 to 10 months. At this age, in order to reduce the duration of the we use the fixator assisted nailing, in which we use the distal entry portal through the heel to pass in the nail, perform the ankle and subtalar arthrodesis in a correct position with about 10 degrees of equinus, and a lower tibial osteotomy for the lengthening. In between, the nail was locked with additional holes and locking bolts. The fixator came 2 months' time in order to give her full correction, and the bone hardened in due course of time under the protection of a removable high-density polyethylene brace and crutches that she wore for the next 4 months. Of course, such an impressive surgery with its low duration of external fixation can also have complications because the surgery itself is much larger than the typical external fixation deformity correction surgery. The surgeries may last from as long as 2 to 4 hours or even more. At least 1 to 2 units of blood transfusion are needed. A special C-arm image intensifier with a large diameter of the C is necessary, and the surgeon of course bears much more radiation exposure during the operation. Of course, we've had our share of complications. This lady with poliomyelitis, in whom we planned an ankle fusion and tibia lengthening as a double level procedure, the nail did not work because X-fix pins became loose. Resort going back to the Ilziarov fixator to perform a second repeat osteotomy at the upper tibia, as well as perform the ankle and subtalar fusion using the Ilziarov fixator. Even though the fixator stayed on her leg for a good 7.5 months, the treatment was completely successful and continued without further incident. This young lady with cerebral palsy with a varus deformity at 2 levels in the femur had a double level osteotomy. Unfortunately, her marrow canal was very narrow and only a 7mm nail could be passed. Due to significant spasticity, she broke the nail, see in this picture, and then we had to convert this, remove the nail and continue her treatment using the Ilziarov external fixator, which allowed her to both the osteotomy levels and gave her an absolutely perfect correction of the femoral deformity. So we now come to the next step of 4th generation deformity correction, which is fixator assisted plating. So when there is a large varus bow leg deformity, as in this lady with significant renal disease with osteoarthritis of the knee, we would not want to perform external fixation high tibial osteotomy, so we chose to perform a fixator assisted plating. You can see the fixator is inserted in the operation theater after a fibular osteotomy, and the outline of the osteotomy is seen with the drill holes. A large X-ray cassette is placed underneath, and a special X-ray machine that we have, which is 10 foot tall, helps us to take full length X-rays to ensure that the correction is accurate. And as soon as the found, we put in a locking plate on the lateral side in order to give her a very good correction without any external fixation and complete relief of pain, which she maintains 8 years after. This gentleman with a very significant varus bowing deformity with pain in both the knee joints would not tolerate an external fixator, and he also had a fixator assisted plating of both his tibia to give him a full. This is another lady with a variant of the fixator assisted plating. She has a significant varus deformity, and we have used the Ilziarov fixator, as you can see, performed a dome osteotomy and used the medial tomofix plate to fix it after accurate correction in order to give her full relief of. Fixator assisted plating can also be done for deformities, as in this medical student from London who came to us with genu-valgum. We started by correcting her. We used the Taylor Spatial Frame Fixator in the operation theater to accurately correct her deformities after dome osteotomies, and with the power of the fixator and accuracy, used locking plates at both the femur and the tibia to give her a complete correction of her deformities with no fixator at all, so that she could fly back to London within 2 to 3 weeks of the surgeries. I will finally leave you with a brief glimpse into the 5th generation of deformity correction. These surgeries were performed by us 3 years ago as the first 5 surgeries with the fully implantable dynamic internal fixation. Here is a gentleman with significant varus deformity. We have performed a medial opening wedge with a precise HDO nail, which has got a drive train and a magnetic mechanism inside. An external remote control is used by the patient to determine the amount of correction that can be achieved gradually and accurately in full correction of the deformities like so. This gives us a brief and yet tantalizing glimpse into the future of the technology that's going to help us to correct complicated in the future. I thank you very much for listening and for watching our website.